facilities. So the number of cases are high, but the vaccination also now the northern province this week, last 2 weeks we have significant number of the people are vaccinated, around more than 50%. Targeted population over 30 year old vaccinated with Sinovac. At the same time, as Vanilla pointed out, the people are the public are now they are not very much aware about the sequence of this pandemic, and the people are thinking that over. Over, like so, same situation like India. But the detecting cases are high. The number of cases are more than 2,000 a day, 2,000, 3,000 a day. But the death rate is not high that much. So now the southern hospitals, specialized hospitals are coupled with these symptomatic patients gradually. So the Colombo, Kurnagal, Rambaga, and Anuradhapuram, like in those area, tertiary care hospitals are dealing with the patients rapidly. So that means that is not good indication. So yeah.
Well, thanks for the updates. It's good to hear the vaccines are getting rolled out somewhat. So keep going with time. Yeah. So
we just have like 14 to 15 participants. So should we just go ahead and say hello with the introduction?
That's probably a good idea.
Yeah. So very good evening once again. This is Vanilla, Program Coordinator from Hyderabad Center for Palliative Care. Once again, I really apologize for the last minute confusion, and we had to cancel our class at 7 p.m. And we have our faculty here now, 8 p.m. session. We are going to soon start, and requesting all the participants to please turn on your video cameras and please put your microphones muted if you're not speaking. If you have any questions, please always you can raise your hand, or also you can always type your question in the chat box. We'll read out the questions for you so that faculty would answer them. And requesting all the participants to please rename yourself, so that it's very, very important to take your attendance. And over to you, Jonathan, would you please once again, I request you to please introduce Dr. Daniela.
Great, yeah. Well, good evening, everyone, and good morning from Canada. Good to see you all again. And we have Danielle down again with us today to talk about palliative sedation. And I think you've all met her before in her previous discussion about nutrition and hydration. Again, she's a palliative care physician in Nanaimo in Canada, which is just near Vancouver here. And also I should just mention Dr. Robin Love is joining us as well. He's another palliative care physician in Nanaimo and has done extensive work over decades in Nepal and other areas of South Asia. So has a lot of experience in that regard. So Danielle and Robin are both working a lot with the Nepal programs. So anyways, over to you, Danielle.
Thank you so much, Jonathan, and thank you so much for having me back. I'm very excited to talk to you today about palliative sedation. Just give me a couple seconds here and I will bring up my slides.
We also have one more guest with Dr. Robin, so can we also...
Oh yeah, sure, I can introduce. So the lovely young lady next to Dr. Love is Dr. Rebecca Wright. She is a family medicine resident, so training to be a family doctor here in Canada. And she's currently also working with us on the palliative care unit for the next couple of weeks. And she has a very big interest in palliative medicine once she's done. So she is also going to join us today just to see how the sessions run and add comments. Thanks for joining us, Rebecca.
Thank you, Dr. Rebecca, for joining us.
Can everyone see my slides?
Yes.
Perfect.
Yeah.
So as Vanilla said, and similar to last time, we're going to go through the slides, but please interrupt me. I don't mind at all if there are any questions or comments. You're welcome to unmute yourself and ask me a question or use the chat function. I'll try to keep on top of everything as well this morning. Before we start, I was just curious, by a show of hands, who before has used palliative sedation with patients in their health center?
Maybe, sorry,
Okay.
if you don't mind, sorry. Maybe so that others follow. May I request you to please repeat the question for the
Sure.
participants? Yeah.
Yeah, I was wondering before we start, if anyone has used palliative sedation before in their health center or hospital. And you can just raise your hand if you have. If you don't know if you have, that's okay. So
Yeah.
a few of us maybe. Yeah.
Sedation, I'm familiar with the sedation, not palliative sedation. But
Okay.
as a psychiatrist, we are sedating the patients, but palliative sedation is new to me.
Yes, great. Okay, well, that's exciting that it sounds like it'll be a new topic for most people. So hopefully a lot of learning will come from today's session.
Dr. Puvikaran says no in the chat box.
I saw that. That's great. So lots of new information perhaps today, which is a fantastic learning opportunity. So today, this is the agenda of what we're going to cover. I'm going to talk about what the definition of palliative sedation is, and also talk about when it might be appropriate as a treatment for our patients. I'm going to talk a little bit about how we achieve palliative sedation. So this includes not only the discussions that we have with each other as the healthcare team, but also the discussions that we have with patients and families, as well as the types of medications that we can use for palliative sedation. I have a couple of cases that we will go through, at least one, if time, we'll have both of them. And then I will summarize at the end with some key messages around this presentation and what I want you to make sure you understand around palliative sedation. The definition of palliative sedation is the process of inducing and maintaining a deep sleep for the relief of severe suffering caused by one or more intractable symptoms when all other possible alternative interventions have failed. So you might have noticed that I underlined a couple of words in that definition, and one of them is intractable symptom. When I talk about an intractable symptom, what I mean is a symptom that is refractory. And this is language that we use to describe symptoms that are not responding despite good treatments that we've tried. So the right medication at the proper dose, and that we've continued to try all other medications or non-medication options for a symptom, but the patient is still suffering. Refractory does not just mean that the symptom is difficult. So just because someone is having severe pain or severe nausea does not necessarily mean it is refractory or intractable. We need to try all possible interventions at good doses before we can say maybe the symptom is refractory if it's not responding. Some of the questions that we can ask ourselves to understand if a symptom is intractable or not could be, do we have other options to provide this patient? And will these options potentially provide relief? Is the relief of their symptom achieved within an acceptable time frame? You can understand if someone is in a significant pain crisis And if they have to wait 3 weeks before their pain is improved, that's probably not acceptable to the patient versus a treatment option that might reduce their pain within a couple of hours or even minutes. And then the other question is our intervention or our management tolerable for the patient? Sometimes we offer patients treatment like palliative radiation or palliative chemotherapy, and this actually causes more symptoms and more harm to the patient than good. So even if we as the medical team feel that an intervention might be beneficial to the patient, if they're not able to tolerate it, then it may not be an appropriate management plan for that patient. And one of the big points that I want to mention is that palliative sedation is not euthanasia. I know in Canada recently, a couple years ago, there was a law that was passed that now allows us to perform euthanasia legally. And my understanding from previous conversations is that's not the case in Sri Lanka. So when you're talking about palliative sedation with families, you need to ensure that they understand that palliative sedation will cause a deep sleep, but it does not immediately cause death. So it is not euthanasia. When a patient has palliative sedation, their body will still follow a natural dying process. And I just wanted to clarify a couple of other things. Palliative sedation is what we would call intentional sedation. So our intention or our desired outcome is that the patient is in a deep sleep. This is different to consequential sedation, which is sometimes what we see as a side effect from our other treatments. For example, higher doses of opioids or benzodiazepines can cause drowsiness or some sedation. But our intent with using opioids or benzodiazepines is to treat a symptom. We're not necessarily using those medications initially to cause sedation. Whereas with palliative sedation, our intent and our goal is that the patient is fully sedated in a deep sleep. And again, these concepts are just something to help you when you're having discussions with patients and family members around what your plan is and why. Because sometimes the patients or families may come to you and say, I don't want to use morphine because it causes sedation. And you may need to have a discussion around the sedation in that setting being more of a side effect versus us giving the patient morphine to purposely put them into a deep sleep. There are many reasons for palliative sedation. I've just listed a few: pain, dyspnea, nausea, delirium, terminal hemorrhage or other palliative care emergencies or crises. And sometimes we see a lot of emotional or psychological suffering that we just have no medication for. And there are lots of others, cases that you might have seen or heard of. So this is by no means a list of all of the different possibilities. There are many others. Much like I spoke about in my last presentation on nutrition and hydration at end of life, when we're thinking about sedation, it's really important before we start to consider the patient and their family. What is the patient's goals of care? Is sedation an acceptable treatment for the patient? And is this something that they would want? So we need to ask ourselves, is it appropriate for us to consider sedation right now? If you remember the definition of sedation from earlier today, we employ sedation when we've tried all other options, and all of the other options that we've tried have not been successful. So we need to make sure that we've asked ourselves, what else is there that we could offer, or have we tried everything? If you're unsure, I recommend getting a second opinion. So this could be a colleague in your discipline, or it could be a palliative medicine specialist if you have access to one in your area. The bottom line is that we need to have clear communication. We need to have a team discussion with all healthcare providers, as well as the patient and the family, to review what our plan is, why we're proposing this plan, and what we hope to see as an outcome. And once we've made a plan, we need to also adjust it as needed. So sometimes, even though we have the best intention, our plan doesn't necessarily work for sedation. So we need to consider backup options in case. And the bottom line here is that we need to be brave. Once you have committed to palliative sedation, you need to stay committed. It's really not fair to the patient or their family or the healthcare team if you start, but then you don't really continue along the plan. It's not as appropriate to just go halfway. So we really need to stay the course, stick to the plan, adjust the plan as needed to make sure that we are achieving true palliative sedation. Here are some medication options for achieving palliative sedation. And you might notice that we use similar medications in other areas of palliative medicine for other symptoms. Commonly in Canada, we will use midazolam, usually given as a subcutaneous infusion. We have a high range here because we can up titrate it fairly easily with respect to each individual patient. We also can use it in palliative care emergencies. So if someone has, for example, a sudden terminal hemorrhage and we need to quickly sedate them, this medication can be used very effectively. The downside to midazolam is that its half-life is too short to work without it being given continuously as an infusion, either IV or through subcutaneous route. So if you don't have the option to give it as an infusion, you may need to look to other benzodiazepines as an option that you can give more regularly, but not with an infusion. So for example, lorazepam or diazepam. And if you're using these, we suggest that you give it regularly every 4 hours, as well as needed. And you'll notice that the ranges here are quite large, potentially, compared to what you've previously prescribed for patients with regards to other symptoms. So for example, you might use lorazepam if someone is suffering from dyspnea or shortness of breath. And the ranges here are large because we don't know how much we will need to give to achieve deep sleep or deep sedation. And so you may choose to start out at the lower end, but we want to make sure that you understand you can go a lot higher. Like we said on the previous slide, you need to be brave. So sometimes we're using higher doses than we normally would because we want to make sure once we've decided on this plan, that's what we're going to stick to, and we're going to make sure that the patient is adequately sedated. And just a reminder at the bottom here, we need to continue our analgesics or opioids for pain control. So the medications that we use to achieve sedation don't necessarily offer great analgesia. So if the patient is on an opioid, that needs to be continued, even if we're planning to sedate them. Sometimes benzodiazepines on their own don't work effectively to sedate a patient into a deep sleep. So we'll need to use other classes of medications, things like neuroleptics, so methotrimeprazine or Nozanan or chlorpromazine. In some cases, if sedation is very hard to achieve, we will need to move to stronger medications like barbiturates. So there's been probably 5 times in my career so far that I've needed to use phenobarbital. And this can be given as an infusion, or it can be given regularly every 4 to 6 hours and as needed. It often needs a loading dose, so keep that in mind if it's not something that you've used before. And then one of the points that I would like to just clarify is that in some countries, in some places, phenobarbital is also used for euthanasia. So we need to be very clear if we are going to use this medication that we're using it for palliative sedation, and the patient and their family understand that this medication, even though it has use in euthanasia, is not being used to provide euthanasia in your setting in particular. So just making sure that our intent around this medication and why we're choosing it is very clear. I would say for the most part, the other classes of medications usually are sufficient at high enough doses to achieve appropriate sedation. It's more rare that you'll get cases where sedation is difficult and you will need to use a medication like phenobarbital. There are also some other medication options like anesthetic agents, things like propofol, etc. But I would say if you're needing to consider those, I would defer to a local or regional palliative care specialist for support if that's required for your patient and your setting. So I think we'll have time to do a couple of cases. So I'm hoping to get a little bit of participation. And so when I ask them questions, if you have the willingness to unmute yourself and answer, or if you want to write in a chat box, that would be lovely. Our first case is a 78-year-old male with metastatic lung cancer. He has disease in his bones, pleura, lymph nodes, and also liver, as well as throughout his lungs. He presents to your local hospital with severe dyspnea. His current medications include a long-acting morphine, 50 milligrams PO BID, as well as short-acting oral morphine that he takes as needed for shortness of breath or breakthrough pain. But he tells you that he finds it difficult to take and swallow when he's really short of breath. So instead, he has been using lorazepam, 1 milligram sublingually every 4 hours as needed. And he tells you he's taking it about 3 to 4 times per day. He understands that he has a severe metastatic illness and that he's going to die from his cancer. He wants to be comfortable, and his wife and children who are with him in the hospital support him. What changes to his medications do you think you could offer to try to relieve his dyspnea in hospital? And I can go back a slide just to see.
And go upon lorazepam.
Sure, yeah, increase the lorazepam, exactly. Any other suggestions? So he was on a long-acting morphine and then also short-acting oral morphine. Would you consider maybe changing the route of his short-acting morphine?
So changing the route rather than oral, considering the subcutaneous infusion.
Yeah, perfect. I really like that. So he was finding it hard to take the oral morphine, which we know helps dyspnea as well as pain, because he was so short of breath. Those are great suggestions. So bad dyspnea can make swallowing pills difficult. So sometimes we consider in these cases changing the route to something like subcutaneous or IV. And we also know that oral medications take longer to bring relief compared to subcutaneous or IV options. So we could consider changing both his morphine and his lorazepam to either subcutaneous or IV. We could consider, as another participant mentioned, increasing the dose of the lorazepam. You might also consider increasing the dose of his short-acting morphine. Maybe the dose isn't enough to bring relief for him in this moment. And then depending on how his course in hospital goes, you might increase his long-acting morphine, or you might change his long-acting morphine to regular formulation, sub-Q or IV. And I think your decision around this will depend on whether he wants to go home or whether he's staying in hospital or a hospice. So It could be either of these. And then obviously we want to make sure that we're optimizing him in terms of his dyspnea in non-medical ways. So sitting him upright in the bed, maybe considering trialing oxygen to see if this improves his sensation of comfort. Having a fan help blow on his face or open a window to get some fresh air into the room. These can also be effective. So a week later, this gentleman is still in your regional health center and hospital. And despite optimizing all of the medications and all of the non-medication options like a fan, oxygen, sitting upright in bed, he's still very short of breath. He is clearly suffering, and he indicates that he doesn't want to live like this any longer. What might you consider now to help him with his symptoms?
I request all the participants to either participate or just put your answers in the chat box. We'll read out them for you.
Do you think that this is a moment in this patient's care where if we've tried everything, he might be considered someone that we would start palliative sedation for? So I'm seeing a few yeses in the chat box. Okay. And someone's saying give midazolam. Okay. I'm just hearing some background noise. Okay, perfect.
I just muted.
Thank you. Yes, so I think that this is a scenario where if you've tried everything, you've consulted with your colleagues about whether or not they have other ideas or options for this patient. And because he's indicated that he's suffering and he doesn't want to live like this, maybe this is the opportunity to have a conversation with him and his family around palliative sedation. So the intent being that he has a retractable or irretractable or refractory symptom of dyspnea that's not responded to any of our good treatments at good doses. And so instead, we will offer him the option of sedation to relieve his suffering. So like I mentioned before, we need to have clear communication with the family and the patient and your healthcare team. And don't be afraid to ask for help if you're unsure about the next steps or developing your plan. So with him, we're going to choose lorazepam. We're going to start it at a higher dose than we've been using previously. So we'll start at 2 milligrams every 4 hours and as needed, understanding that because of his symptoms and how severe they are, we may need to go up on this dose fairly quickly. So in order to titrate to a deep sleep, we will need to increase the dose or add in potentially other agents as needed. And he was on long-acting morphine for pain, which I mentioned before we need to continue. But we have to remember if he's going to be sedated, he won't be able to swallow long-acting morphine. So now we must change the route of morphine to IV or subcutaneous. And because there are no long-acting versions that are able to be given IV or subcutaneous, it will need to be given regularly every 4 hours and then every hour as needed as a PRN as well. So after another couple of days, you've up-titrated the lorazepam to 4 milligrams every 4 hours subcutaneously to maintain a deep sleep or sedation. And he does die comfortably with his family at his bedside a few days later, and his symptoms were controlled. Any questions about the case?
Anyone would like to comment or ask? Any questions or do you want to comment? Anyone?
Okay. If you think of a question or a comment later, just put it in the chat box or we'll have some time at the end. So we have one more case to review, and then I'll briefly summarize some key messages. Our second case is a young woman, she's 45, with glioblastoma. She was admitted to your hospital after seizures at home. She lives with her husband and her young son. And the plan for her, according to her family, is to try to return home if her symptoms are well controlled. She says that her headaches are a lot worse and her pain is not controlled compared to previous. This is the first time that she has had a seizure and had several at home today before she was brought into the hospital. She doesn't remember having her seizures. This is all coming from her family who witnessed them. She did not sustain any head trauma or any other trauma as a result of the seizures at home. And when you speak to her, she can remember the events earlier in the day, and she does seem clear and lucid and not confused. She can tell you that she's previously had radiation to her brain for the tumor and was told by the radiation oncology team that she cannot have any further radiation. And she's not a candidate for chemotherapy. So she's currently not receiving any intervention from the oncology perspective for her glioblastoma. These are her current medications. She's on prednisone 10 milligrams orally once a day, and she's only taking short-acting morphine as needed for pain. She has a 5 milligram tablet, and she's taking about 4 to 6 of these per day over the last couple of days as her headache or her head pain was increasing. I'm curious if you would want to order any investigations, and if you do, what would you consider ordering for her? Do you think that ordering some imaging would help you make a different plan for management?
CT scan that showed the hemorrhagic.
CT scan, yeah. And I'm seeing a couple of responses in the chat box as well. So a CT scan, I'm assuming of her brain, just to get a sense of where her tumor is at. And I think that if it was available to you in your area would be appropriate, because it may change what you may offer her from a symptom management standpoint. So when we do the CT head, it does show enlargement of her glioblastoma, which is almost now doubled in size compared to her last CT scan about 2 months ago. So this information may also help us to predict her prognosis as well. A question that maybe sometimes the patient and the family will ask you, how much time do I have left? We also see on the CT scan that she has significant edema around the tumor, but there's no mass effect in her brain. What would you offer to manage her pain? Are there any changes to her current medications that you could make that may help her? So she's on a lower dose of prednisone and then also just as needed morphine. Yeah, I'm seeing so IV Dex, so maybe a dose of intravenous steroids, maybe a higher dose than what she's getting orally. Would you make any changes to her pain medications?
The participants are so quiet. Yeah, someone says regular dose of morphine.
Yeah, regular dose of morphine. Sure, yeah. And I agree with the regular dose of morphine, just considering how regularly she's been needing it over the last couple of days, which makes sense now that her tumor has grown quite substantially. Are you worried about more seizures in the future? Is she at risk of seizing again?
Someone says haloperidol.
Okay. And I'm also seeing a yes for more seizures. And I think haloperidol is an excellent medication that can help for other symptoms like potential nausea. So with an enlarging tumor in the brain, sometimes you can see patients present with very severe nausea. So haloperidol can be quite effective for that. Haloperidol can also be very effective if a patient with a large brain tumor is a little bit more agitated because of the tumor in the brain. That can also be an effective use of the haloperidol. And then there's a suggestion about adding on midazolam. So potentially having a benzodiazepine available at home in case she was to have a seizure again. The family wasn't anticipating the seizure this time, and so they brought her into hospital because they didn't have any way of treating her. So I think we could continue either a more regular short-acting medication, or ideally, if you had it available, changing her to a long-acting pain medication. So for example, something like morphine 10 milligrams orally twice a day, the long-acting version, and then continue to allow her to use the short-acting breakthrough as needed. And I think that we should probably increase her steroid dose at this point. So whether that's dexamethasone or we give her a higher dose through the IV first because she's in hospital, but I would consider continuing a steroid at a higher dose since she wants to go home and spend time with her family. So depending on what you have available in your area, perhaps in this case, we've gone up to 50 milligrams once a day of prednisone orally. But if you have dexamethasone available, you can also use dexamethasone. And that dose could be anywhere from 4 to 8, sometimes even higher, depending on the case. And then I've also seen patients be put on anti-seizure medications. I will admit that as a palliative care physician, I'm not often the one prescribing these, but I often see patients on the palliative care unit here, or when I'm doing a home visit, who've been put on anti-seizure medications by other specialty areas, whether that's internal medicine or neurology or oncology, because they've had seizures related to their brain tumor. I think the big point that we need to make sure you understand is that no matter the dose of the steroid or the combination with an anti-seizure medication, as the brain tumor progresses, her risk of seizure will increase, and there will become a time when we may not be able to control seizures regardless of the medications or doses that we use. So unlike anti-seizure medications in a seizure disorder like epilepsy, when the seizure is coming from a brain tumor, they may only work for a shorter period of time compared to our use of these medications in other patients. So she's able to get home for almost 2 months, but unfortunately returns to your hospital with recurrent seizures back to back that are not responding at home. She's minimally responsive when you see her. She's confused. She does open her eyes when you speak to her. She has a seizure while you're trying to speak to her and examine her, which lasts for about a minute. It's a grand mal or tonic-clonic seizure. It resolves on its own, but she's quite confused afterwards. She appears uncomfortable, and her husband and son who are with her are afraid that she will die in pain and that the seizures won't stop. Her medications right now are prednisone 75 milligrams once a day, and she's increased her long-acting morphine up to 50 milligrams twice a day for increasing headaches or head pain over the last several weeks. And her husband had diazepam at home, which he tried to give orally, but had minimal success and effect on her seizures. So she's had several back to back to back. What do you think we could give her to try to control seizures in hospital? Are there changes that you might make to her medications, or maybe the route of medications to see if it's more effective? Yeah, so I'm seeing a suggestion of midazolam. Definitely a possibility. Midazolam is a great option because it can be given subcutaneously very quickly or through an IV, or even sometimes we've used it intranasally, so spraying it up the nose. But remember that midazolam is very short acting, so it might be useful to control a seizure. But if we were planning to do palliative sedation, it would need to be given as an infusion. Any other options for medications?
Phenobarbital.
Phenobarbital, possibility if we needed to go down the route of sedation. It probably wouldn't be the first one that I would choose, but I think it's an excellent option or medication if you've tried benzodiazepines and other interventions first and it wasn't working. Excellent. I might consider switching her steroid medication to IV or subcutaneous. It doesn't say in the case how her swallow has been or if she's been able to routinely take her steroid, but we could also try increasing the dose of her steroid to see if that may help buy us a little bit of time or some extra days where she doesn't have as many seizures and she could be a little bit more clear and lucid to have conversations with her family. If our treatments didn't work, do you think that palliative sedation in this case is appropriate? If we've tried what we feel is everything and she continues to have seizures, she continues to appear in pain, her family is worried about her dying, just seizing and not having good symptom control. I'm seeing a few nods and a yes in the chat box. Yeah. From my experience, patients that have a primary brain tumor or cancer that has spread to the brain as metastatic disease, these can sometimes be really hard patients to manage. They can sometimes present very confused. Sometimes they're very agitated. Their personalities can change. Sometimes they have, similar to this patient, recurrent seizures that are really scary for family members to witness in the home. So these can be tough patients to support. And I think if we've tried everything, this is a good opportunity to talk about palliative sedation in terms of bringing symptom relief and allowing her to rest comfortably in a deep sleep until her body is ready to die. So similar to what we talked about before, asking your colleagues for help, coming up with a plan, maybe midazolam if you have the ability to run it as an infusion, and then making sure once you start that you continue ensuring that she's sedated and comfortable, because the risk is if we don't ensure she's sedated and comfortable, she could still be at risk of having a seizure, or she could still be in pain or discomfort, but sleepy, which is not the outcome that we want. what medications do you have available at your hospital or health center for palliative sedation? I'm just curious if you want to list some in the chat. I know from the one trip I had to Nepal and some of the work with Dr. Love and I in Nepal that different medications that we use in Canada sometimes aren't as available in other parts of the world. So I was just curious if there's medications that I've spoken about today that you have never seen or used, or if there are other medications that I didn't mention that you use in your hospital. You can just write names in the chat box, or if you want to unmute yourself, that's okay too. So midazolam, I'm seeing.
Yeah. Usually we have midazolam, IV, IEM subcutaneous, and diazepam. Also different routes we have, but the lorazepam is commonly not using in the hospitals in Sri Lankan setup.
Okay.
Oral we have lorazepam, but IEM, the other parenteral route not available.
Okay.
We have haloperidol, IEM, phenobarbital. These are available.
Okay.
Instead
Great.
of lorazepam, usually commonly we are using the midazolam.
Okay, good to know. Thank you for the feedback.
Dr. J. in terms of antipsychotics, obviously your experience in psychiatry, what's the most sedating injectable antipsychotic you would have available? I don't think you have methyltrimeprazine there from our previous conversations, so.
Sorry?
I don't think you have the methyltrimeprazine available there from our previous conversations. So I was just wondering what other sedating antipsychotics you have to give by injection.
Yeah, in the government hospitals, we commonly have haloperidol and midazolam. Some private hospitals they have fluoxetine and risperidone.
Okay.
But these are very expensive in the government sector. We cannot get.
Do you
Okay,
have chlorpromazine?
Sorry?
Do you have chlorpromazine?
Yeah, chlorpromazine we have. We have chlorpromazine.
So that would be a good example of an old-fashioned, quite sedating antipsychotic that you could use in this circumstance if you need to.
Yeah, sure.
Great. Thank you everyone for your input and discussion. That was very good. So just in the last couple of minutes here to wrap up, one of the key points that I want to make sure you understand is that palliative sedation is the recommended treatment for an intractable symptom. So a symptom that is refractory, meaning none of our other treatments, good medication choices at good high doses have worked. And remember, palliative sedation is not euthanasia. So palliative sedation induces a deep sleep, but it does not immediately cause death. It is different from euthanasia. A patient with palliative sedation will still follow a natural dying process, and their body will die when their body is ready. Palliative sedation requires a clear plan that is well communicated with the patient and the family, the reason why you're offering it, what the outcome will be, and why you're suggesting this. And you also need to have a clear plan with your healthcare team. What medications are we going to use first? What doses? When would we consider adding in a second medication or a third medication if we need to? And how are we going to monitor when these medications or doses need to be changed? And then remember to be brave. This can be a difficult intervention, because it changes how the patient appears to you. So a patient that is awake but heavily breathing at the side of the bed, that 78-year-old male with lung cancer who can't catch his breath, but he can open his eyes and look at you and tell you that he's suffering, looks very different to that 78-year-old patient who's lying in bed, comfortable in a deep sleep. It can be a very dramatic feel in terms of the change. So once you start, stick to your plan. Don't just go halfway, because that's not appropriate for the patient or their family. And remember that we need to continue analgesics and opioids for pain control. Our sedative medications work for sedation, but we also need to continue something to help control their pain if they were having pain and on a pain medication previous to our intervention of sedation. And that's it. Any questions or comments? This is one of my dogs. I have 2 puppies. She's from the northern part of Canada where there's a lot of snow. So she likes the very, very cold weather, as you can see. So if you have any questions or comments, feel free to put them in the chat. Again, thank you so much for having me. I'm very honored to be a part of your learning today. I will pass on to Vanilla my slides for you to have access to after the fact. And Vanilla also has my email if you do have any other questions or comments that you think of in the upcoming days or weeks. I'm more than happy to receive an email from you and answer the questions that way.
So anyone has any questions? We still have 5 more minutes. Yeah, Dr. Janathan, do you have something to say? Or
I was just gonna ask people if there any thoughts on this topic, and from a ethical and cultural perspective in Sri Lanka, whether you feel like your colleagues in your hospitals would be in agreement with this type of intervention. What are your thoughts and your own feelings about this type of intervention? Because sometimes people feel very uncomfortable with the idea of intentionally sedating people until the end of their life. I've also encountered some people with different faith backgrounds or religious beliefs around the importance of maintaining consciousness and awareness until the end of life to kind of help with the dying process and moving on to the next life kind of journey. So I was just wondering people's response or feelings around that palliative sedation.
Yeah, good question. Usually usually we are discussing about the conditions. Usually the specialized doctors they are calling the family members and having a family meeting, and they are discussing about the prognosis of the condition. Usually when we are not very specifically talking about the palliative sedation and all, just informing the mainly the prognosis of the disease or the condition. So the actually not exactly explaining these palliative sedation, all those things. Some units, some specialists, they detailedly they will discuss about this condition.
I think it's just very helpful to be clear in terms of what Danielle was saying earlier around keeping it very, very distinct from euthanasia and intentionally hastening the patient's death, because that obviously has very significant different ethical and personal implications, how people feel about that. But I usually just try to explain it to family members as, we're just really trying to help the person to be asleep and unaware until they die. And it's until they die naturally. And it's not something we're doing to try to speed things up. So it's, but yeah, different people have different perspectives on it. And I think it's, as Danielle spoke about too, it's really important to talk with the family, and sometimes we're able to talk to the patient, but the two most common reasons that we need to use palliative sedation is for really severe agitated terminal delirium, and really bad terminal dyspnea. So sometimes it can be often hard to have conversations with the patients, and usually it's the family members we're talking to. But anyways, I'd encourage you just to think about it for yourself, how you feel about this topic, and also amongst your own hospitals and other staff members, how you would manage this type of very end stage severe suffering for patients, because it's, I think, important to help manage patient suffering, but also for family members and their own grief experience after the patient has died, to watch their family members suffer a lot at end of life can make the grief process more difficult for them as well. So it's an important topic to think about. But
yeah, for how long we can keep in the palliative sedation? Is there, any?
Yeah, so usually we people to be candidates for palliative sedation, we think of them needing to have a natural prognosis in the last few days to maybe maximum couple of weeks of life, but usually it's kind of in the hours to short days kind of category. If people are thought to have a natural prognosis that's longer than that, then usually we're not thinking of them as candidates for palliative sedation. And in the Canadian context, they might be considered for things like euthanasia if that's what they were wanting to pursue, but that's a very separate pathway and assessment process and all that kind of stuff. So
Also, Jonathan, I think part of the question was about how long we keep people sedated. And I think the answer also is in the hours to days, sometimes a week or two.
Yeah.
Thank you.
If I can make one other comment, if I have a patient with, for example, bad dyspnea, and I'm anticipating that this may be difficult to manage, I might have the conversation with the patient and the family a little bit earlier, saying, we're going to try several things to try and manage your dyspnea, but if we're not able to control it, then we can use palliative sedation. And just reassuring them that we will not leave them feeling like they're suffocating or choking, that if we have to, we will give them enough medication to make them deeply asleep. And that's very reassuring to the patients. People who have been very short of breath are usually very worried that they're going to have a terrible death where they suffocate or choke. And we want to be able to reassure them that we won't abandon them and leave them choking and gasping.
It's a very good point. Yeah, and the conversation around it we had even earlier in illness, before symptoms become severe, if people are expressing fear or worry about that, particularly patients with lung disease or lung cancer can often talk about being worried about suffocating at the end. So
and, unfortunately, in our setup, the patients, those who needs palliative sedation, unfortunately, due to the lack of space and human resource in our settings, these patients are not getting beds. So, is it any possibilities to the home-based palliative sedation?
we do that in Canada. There are sometimes infusion pumps that can be run with under the skin infusions, or even just regular medications being administered. You'd have to be able to be dispensing the medications by injection, probably from the hospital in your case. So it is possible. The other option is places like hospices that are outside of the hospital. And I know in Kane there in Jaffna, there is a hospice that tends to not be so much for end of life situations, but in the future, if we were able to get it up and running more as a hospice, regular hospice setup, then palliative sedation may be able to be offered in that type of setting.
What about hydration and nutrition during the palliative sedation?
Good question.
Yeah, go for it, Danielle.
When we've come to the decision around palliative sedation, we're not giving artificial hydration or nutrition. So the patient is in a deep enough sleep that they're not experiencing hunger or thirst. It's a very common question we'll get from family members of the patient. And so what we typically do is we reassure them that because they're in such a deep sleep, they're not suffering from hunger or thirst. And our interventions, like I spoke about last presentation, for example, intravenous fluids, in the stage of palliative sedation is likely to do more harm than good. So cause potential respiratory congestion or increasing edema in the sacrum or the legs, and therefore cause pain. So at this stage, I wouldn't add in artificial hydration or nutrition if I was doing palliative sedation. If someone was already on an intravenous, for example, they had some fluids being given and we were pursuing palliative sedation, I would probably wait until they're deeply sedated and I feel comfortable that they're sedated. And then I would likely stop some of those interventions, the artificial hydration or any feeding.
Yeah, so even like I would like to share, like I think a couple of years back, like we asked to, I think Dr. Jayarasa has asked a question because lack of space. So once we had to plan a palliative sedation in in our palliative care OPDs. So, and as Dr. Jonathan has mentioned, like culturally, like families may not accept, like, and the mother said, like when we spoke to the family about palliative sedation, the mother said, no, how can I do this to my child? So initially they didn't agree, and after a day, like the parents, like the family members got convinced. They came back and we had to really sedate their son, a child, and an adolescent child, and explain like it's a process anyways, he's going to die, and then so that he doesn't know the suffering, and we are not able to deal with those intractable symptoms, and we had to convince the family and we had to sedate the child, I remember. And also to Dr. Jayarasa's question, because in Hyderabad we do home-based palliative care program, there are families and the doctor, our home care doctor plans for a palliative sedation, the family members are given like proper loaded injections like once a day. So the family members have to come, and then depending upon the doctor's note, we have to refill the medications, load them, and then give them back with proper labeling, etc., and send them. So typically, yeah, we have done palliative sedation in our outpatient setting, we have done in inpatient setting, and also in the home setting.
I think for palliative sedation to be successful at home, like Vanilla is saying, it really requires a very strong team of family, because we don't have the capability, at least in Canada, and I'm going to assume in India and Sri Lanka, to have a doctor in the home or a nurse in the home 24 hours a day. And so the family members need to be comfortable with giving the medication and understanding when to give extra medication, etc. And so if you're feeling like there isn't a strong family, for example, maybe an elderly couple and it's just the two of them at home, their children live farther away and can't come in to help, it might not be a feasible option to consider, because one person doing it can't be awake throughout the day and the night for many days or possibly a week on end to administer medication. So I would say that it's absolutely possible. It just takes a lot of coordination and planning. and a really clear discussion with the family about the types of medications, when to give them, why to give them, etc.
So any questions? Any more questions or thoughts? If there are no questions, so shall we just wind up the session? Dr. Daniela and Dr. Sanathan?
Sounds
Yeah.
good. Thanks
Yeah.
very much.
Yeah, so thank you everyone for participating in the discussion, and thank you Daniela and for such a wonderful session like last time, and thank you Dr. Zanathan and Dr. Robin for joining us. So I request all the participants to please share your valuable feedback with the link given in the chat box. This is very important for us, and we'll all be seeing you on next Wednesday, 7 p.m. The date is 11th August. There are 2 sessions planned. One is the overview of pediatric palliative care and cerebral palsy in palliative care. So we'll all see you next Wednesday, 11th August, 7 p.m. Thank you, and please do not forget to share your valuable feedback. Thank you all. Good evening, good morning, and good night.
Take
Thanks,
care,
everyone.
everyone.